This program is brought to you by Stanford University. Please visit us at stanford.edu.
This presentation will be used for off-label or out-of-IFU purposes. So currently, as I think many have alluded to during the last 2 days, there's basically two different ways to repair abdominal aortic aneurysm surgically. The endoaneurysmorphy technique, originally described by Creech, has been a staple in the United States for 50 plus years. And more recently, of course, due to the efforts of Dr. Ahrens and our faculty, as well as others interested in this area, we've had access to endografts here for investigational purposes since the early 1990s. But, I mean, you know, we see these slides, we see an either-or thing, but the evolution of EVAR has been a juggernaut in the sense that it's the number of open operations we're doing at current time is rapidly approaching basically zero. If we look at the evolution of EVAR, as originally introduced by Perotti in 1991, the first commercially viable device used clinically in the United States was the EVT device, originally by EVT and then Guidant. By roughly 2004, I'm not precise on these numbers, EVAR was at least 50% of total aneurysm repairs in the United States. Number of retrospective reviews and Medicare database reviews have demonstrated that both the United States, the UK, and in other countries, EVAR has significantly reduced perioperative mortality. No question that in general, across a population-based approach to surgical repair, that EVAR is safer, especially in the first 30 days after the procedure. It's also associated with remarked reduced length of stay, reduced incidence of nursing home discharge, and increasing apparent utility in the use of ruptured aneurysms. I have some examples of that. If we look at how EVAR has impacted our surgical practice, this data here is kind of fuzzy because it comes from our resident case logs mostly, and there were some investigational devices that some faculty were placing here as early as 94 and before, but at this juncture is when clinical testing began of the Aneurysm devices, and we see that by 99, because we had exclusive access to some investigational devices regionally, our surgical volume had basically doubled as a consequence of the contribution of EVAR. After the introduction of these devices clinically, the total was reduced, and over the next several years, the proportion of open versus endovascular stayed roughly the same, endovascular being in red. However, since about 2003, due to the availability of either investigational use IDE, suprarenal fixation devices, or the commercially available Cook device, EVAR has just had a steadily increasing percentage of our practice. And for this last academic year, we performed at the University Hospital here a grand total of 20 open abdominal aortic aneurysm repairs, which is 1/4 the number that we performed in the year 2000. And honestly, if you look at these 20, about half of them are open revisions of previous EVAR cases for various issues related to device failure. And you know, we're reaching the point where the individual faculty members on our faculty are performing just a handful of these operations a year. And as we look towards the introduction of fenestrated branch grafts and other devices that increase the applicability of EVAR, you know, it's possible this number could, you know, essentially go to zero. And it's important to recognize that there's a couple of different themes in reviewing this literature. This were referrals to us based on exclusive availability of EVAR devices. These were referrals to us based on community still being a little bit uncomfortable with EVAR and skill set hadn't fully developed. These referrals are coming to us mostly at this time because they're patients who aren't candidates for endovascular repair, and there are some vascular surgeons in our community who no longer perform open repair, period. If they can't do an endovascular graft, they'll refer the patient to us for open. And in the last couple of years, I've been getting specific referrals for patients who are not felt to be endovascular candidates at their local site, have been told or don't want open repair and want another opinion about having an endovascular repair place. So, you know, despite the good intentions, the OVER trial and other studies like that, the reality of the marketplace is that incidence of open repair, at least in our practice, and you have to understand the specific issues related to our practice, is significantly decreasing. This is one of the last open repairs I performed, actually. 75-year-old woman with large aneurysm, bilateral iliac aneurysms, and a concomitant 5-centimeter thoracic aortic aneurysm, and she was treated with bifurcated open endovascular or open surgical repair with renal artery reimplantation in July of 2007, and then 2 months later, came back for percutaneous treatment of her thoracic aortic aneurysm with a good surgical result. Much more common for us now in our practice is this kind of thing. 75-year-old man, 8.5 centimeter aneurysm, morbidly obese with a symptomatic coronary disease. He has, you could argue what his life expectancy is going to be, but he has an aneurysm that has a size that would suggest a high rate of rupture within the next year. He has an 80 millimeter angled, 12 millimeter long neck, 80-degree angled neck, 12 millimeters length. And by using, as Jeff Rubin was pointing out this morning, if you looked at the axial images here, you might be a little concerned about neck length, but if you can view this on a 3D workstation and figure out neck lengths, you get a little bit more sense of what's possible. We're able to put suprarenal fixation device into this patient, and at 12 months it has sac reduction to 53 millimeters. This is just kind of giving you an overview of what's possible today with clinically available endovascular grafts. This is a 59-year-old Asian man who presented to another hospital in our area with a cold right foot, diagnosed with thrombosed popliteal aneurysm. Under fluoroscopic guidance, a thrombolytic catheter was advanced into this area, and it was only on follow-up imaging that they noticed that, oh, by the way, they'd advanced this thrombolytic catheter through a large abdominal aortic aneurysm as well. And so he presented with a threatened limb and 8 centimeter aortic aneurysm with a 90-degree neck. So he was managed intraoperatively by simultaneous revascularization of his right lower extremity, as well as placement again of a suprarenal fixation device, which successfully excluded his aneurysm, and at the 1-year time point had a good surgical result. He had a contralateral popliteal aneurysm that was repaired electively with a percutaneous approach. There used to be some, kind of bugaboos about endovascular repair. For example, status of the colon, particularly in covering patent IMAs. This 75-year-old man, 2-vessel symptomatic coronary disease, 6 centimeter aneurysm, 32 millimeter diameter neck, 5 millimeter length, calcific and narrow iliac arteries. He also had a widely patent IMA. Doesn't show up that well on this CT reconstruction. So as you can see here, he has a celiac stenosis, SMA occlusion. So the question was, would this be a problem if we treated him endovascularly with his angina, which he experienced multiple times a week, took nitroglycerin for. And so we have some options in this regard. We've been testing this Tstat device from Spectros for colon oximetry. We can place an oximetry probe in the colon prior to the procedure. We deploy the endograft, and we can actually see on this time scale that the time the main body is deployed, contralateral leg is deployed, there is a relative amount of ischemia present in the colonic mucosa. But then over these, I think these are 15-minute cycles, and within an hour, he was at baseline colonic oximetry, even with complete occlusion of his inferior mesenteric artery. He went on to have unremarkable surgical recovery and had no post-operative evidence of colonic ischemia. This is a patient referred to us with systolic blood pressure of 100, a CT scan done in a hospital in the Valley for presumed kidney stone, done without contrast, demonstrates a ruptured abdominal aortic aneurysm, helicoptered here. At the time he arrived here, he had no palpable pulses. He's taken to the operating room, and within an hour, we were able to place an endograft and exclude his ruptured aneurysm, and his blood loss was 150 ml, which for the surgeons in the group just drives home the potential applicability of this treatment modality in terms of improving patient outcome. And at the 1-year follow-up point, he's back at work and doing relatively well. So these are the approved instructions for use in the United States for FDA-approved endograft devices. Currently, there's a recommended 10 to 20% oversize for the devices as listed in this area for neck diameter. Neck length is 10 to 15. I think Talent Device is the only device that carries approved recommendation for 10 millimeter neck length. 60-degree angulation is less is required for all devices. Dorothy Abel's here, so if I'm off on any of these, Dorothy, please correct me on that. Native iliac diameter is in this range. Iliac length, all devices require at least a 2 centimeter distal seal zone for all devices, and some devices have a bell bottom option, some don't. and then there's some differences in terms of the taper that's available distally. But suffice to say, in our practice, we're making these devices work for currently 90+% of the aneurysms referred to us for surgical repair. So, I mean, it's one thing to say what's actually happening. It's another to say what evidence exists to support this evolution in practice. And actually, as Frank, I'm sure, will tell you, the evidence to support this is really fairly thin. There's the EVAR 1 and 2 trials published in the UK with longer-term follow-up. There's the DREAM trial in the Netherlands that had shorter follow-up, and there's the OVER trial in the United States, all RCTs, which have not, as of yet, OVER trial has not yet presented its outcome. Recently, Mark Schimmerhorn published a couple of papers in the New England Journal of Medicine using Medicare database reviews, trying to do propensity scores, although the patients obviously were not randomized. He tries to make the groups of open versus endovascular repair as comparable as possible, and then look at outcome differences between the two. There's continuing issues about cost effectiveness. There's continuing issues about exactly what's the best method of surveillance, as you've heard discussed here at the meeting earlier last 2 days. And then finally, there's some controversy about exactly who should be treated with endovascular treatment if, in fact, the outcome is so good and the devices are so durable. So if we look at the EVAR 1 trial data, which is no longer new, really, obviously this was published in 2005. These patients were randomized in the UK to open or endovascular repair. They had to have the right anatomic criteria for endovascular repair. They had to be surgically fit enough or physiologically fit enough for open surgical repair. And at the 4-year time point, there was a slight significant difference in terms of open versus endovascular mortality, but their open mortality is generally higher than what's reported in the United States. Aneurysm-specific mortality, there was no difference in all-cause mortality. If patients who were screened for that test had anatomy that was appropriate for endovascular repair but were not considered to be physiologically fit enough for open repair, they were then offered participation in the EVAR 2 trial, which was endo versus surveillance. And there's kind of an eye-opening result of this case was that by life table analysis at the 4-year endpoint, there was very high mortality in either the treatment or the observation group, aneurysm-related mortality and an eye-opening mortality for all cause. But as I'm sure most of the surgeons in this audience are aware, there were a number of issues related to this trial. First, there was some problem between time to randomization and treatment. Obviously, there's more information now about what best medical treatment might be. At the time, there was no specific medical treatment offered, and there was a very large number of crossovers where people basically just changed their mind and said, you know what, I want to get that aneurysm fixed anyways, and the data was actually presented as intention to treat. So suffice to say, for patients who are older, sicker, and at higher risk, this is not really definitive in terms of what the likely outcome might be. So this is actually Mark Schimmerhorn's recent review in the New England Journal of Medicine. Basically, they took the total number of patients, some 60,000 patients who'd undergone abdominal aortic aneurysm repair in the United States paid for by Medicare between 2001 and 2004, and tried to use this propensity score to try to make the open versus endo patients as comparable as possible, and the ones that weren't comparable were just left out of the analysis. And you can see in general, in terms of age groups, race, comorbidities, they were fairly successful in being able to achieve some comparable comparison groups, although again, this is a retrospective analysis. And we see that, as has been the case in almost every study, mortality was significantly lower in the endo versus the open repair in all age categories, particularly in the most aged patients. And that also, very importantly, especially for older patients, the incidence of nursing home discharge was much higher in patients who underwent open repair. If we look at aneurysm-related re-intervention, it was significantly higher in endovascular versus open repair by year 4, which doesn't come as a huge surprise. And in fact, if you consider that in the early 2000s, the incidence of secondary intervention following EVAR was in some single-site series as high as 10%, or 10% per year or higher, this difference is actually not that dramatic in terms of year 4, especially considering the magnitude of most secondary interventions for EVAR. We can see the difference here in major re-interventions versus minor re-interventions, and minor re-interventions being defined in this lower category. One thing that Mark considered in his review, which has not been considered in other similar comparisons, was that there were some secondary operations needed for open repair as well, and specifically for laparotomy-related complications. By year 4, there was 4%. I'm not sure why those patients needed laparotomy, but there was 4% in the endovascular repair group versus 9.7% in the open repair group, and this was related mostly to incisional hernias and bowel obstructions related to presumed adhesions. So clearly, this review, both EVAR 1 as well as Mark's overall review, demonstrate that EVAR is a very safe procedure, at least through 4-year follow-up. There are, of course, some lingering concerns about long-term durability of endovascular devices, and recently the FDA reminded surgeons to review the device-specific websites because they're particularly concerned that at some later time points, aneurysm-related mortality might increase on the basis of some devices. And I think that under the circumstances, it so happens that this particular device has longer follow-up available, and I think the take-home message from this report was primarily that this is something people have to continue to be aware of based on the devices they're placing. I do think, however, this does call into question whether EVAR is necessarily the right thing to offer patients with smaller aneurysms, especially considering the data we discussed yesterday that a significant fraction of smaller aneurysms may never progress to the point where surgical repair is indicated. There is obviously data to demonstrate both anecdotally as well as controlled series that devices do have some issues with long-term durability. These were images provided to me by one of our radiologists here at Stanford. This is a patient with 7-year follow-up after EVAR, and if you could see these actual measurements, you see very little difference in the distance between the superior mesenteric artery and the proximal portion of the graft through about 3 years and 9 months. But by the 6-month interval, that distance of 25 millimeters had increased to 34 millimeters. And by the 7-year interval, we're up to, I think it's 55 millimeters distance, clearly showing that, you know, even well past the 3 or even 4-year time point, it's still possible for there to develop late problems with the device. And this just shows a better image technique to demonstrate the actual position of the device in relationship to the aneurysm. As you can see, it's kind of backing out of the neck there. This is a smaller aneurysm that has a different device place, showing that this is not necessarily device-specific or aneurysm morphology-specific. This is the pre-op image. This is the immediate post-op image. This is 6 months. This is 1 year. This is 2 years. And this is 3 years. And either the aneurysm itself is lengthening or it's kinking in the middle. I know Chris has some interest in this area, but clearly there's an increased distance in this area. Rod White has considered the possibility the aneurysm neck itself is enlarging. But again, this drives home the point that although most of us are convinced that EVAR is a better option when anatomically feasible in the early postoperative period, that surveillance is essential to optimize patient outcome. This is another patient, another device, different aneurysm. This is December 2003 pre-op. This is March 2004 post-op. This is April 2004. This is November 2004. And this is June 2006 with complete failure of proximal fixation, again emphasizing the importance of long-term follow-up. Unfortunately, as someone else alluded to today, outside of clinical trials, there's no absolute requirement for surveillance. It varies based on patient anatomy, device issues, patient suitability for postoperative imaging scans. Current practice, in fact, is highly arbitrary. There was recently a paper published in the Journal of Vascular Surgery comparing outcome in patients who'd undergone FDA-supervised trials with mandated surveillance versus the patients not exactly contemporaneous who'd undergone repair and part of their clinical practice. And their conclusion was that outcome was not necessarily equivalent in clinical practice compared to protocol-driven clinical trials because of this issue of slippage and endo leak. Costs and risks are clearly increased by these lifelong imaging requirements, and clearly we need some more guidance in terms of combining all the things we've talked about at this meeting. Wall stress analysis, biomarkers, a variety of novel imaging techniques, better understanding of what exactly puts an aneurysm at risk for continued remodeling both before and after endografts are placed, get a better sense of how to personalize surveillance requirements for each patient who's had an endovascular repair. There have been a number of studies looking at relative cost effectiveness in a prospective, retrospective, or modeling fashion. In each of these studies, there are some issues with the methodology, but interestingly, every study that's ever been published for elective aneurysm repair suggests that EVAR is not as cost-effective as open repair, but you see this is almost moot at this point if nobody's actually getting open repair. The relative cost estimates change over time, but as I said, they generally weigh on the side of EVAR as being more expensive. Device costs represent a very significant fraction of total hospitalization. At our hospital, for these severity-specific DRG scores, for example, MSDRG 237, if we wind up using more than 3.5 pieces per case, we've lost the ability of the hospital to make any money on that particular patient hospitalization and treatment sequence. And the only exception to this situation currently has been there's some evidence that in the situation of ruptured aneurysm repair, like that patient I showed before, the ICU stay and all that far outweigh the expenses related to the original repair, and there appears to be clear evidence of cost effectiveness in that situation. Because of the surveillance requirement, there have been some estimates that postoperative surveillance can increase, and follow-up care overall can increase costs following EVAR by $1,000 to $2,000 a year, perhaps resulting in a 44% increase over 5 years. This analysis, and whenever these papers get published, we get tangled up in these issues about the significance of type 2 endo leaks. This paper, for example, is from the Ochsner Clinic, and this series included an earlier time period when they were doing catheter-based interrogation of type 2 endo leaks that most of us don't do anymore. And, looking at historical norms for current cost comparisons has some problems inherent in it. I wrote an editorial in the Journal of Vascular Surgery talking about this, but clearly there are long-term costs associated with EVAR that have to be calculated into those cost comparisons as well. So, in summary, for us, speaking for myself, but also in general our group, just at the university, not necessarily the VA, those numbers were just university numbers. For us, this year, aneurysm repair is basically EVAR with very few exceptions. There's not a huge amount of randomized controlled data, long-term follow-up to support that surgical approach, but the short-term data is strongly in favor of EVAR, and again, the over trial might provide more guidance on that. EVAR has clearly expanded treatment capability, reduced peri-procedural risks and hospital stay. It's clearly a huge improvement in the management of emergent or ruptured aortic aneurysms when at all possible. It's uncertain about this impact in older and sicker patients, and I don't think the EVAR2 trial is definitive in that regard. It changes the management of the surgical repair from just a set it and forget it situation to an active management paradigm requiring lifelong surveillance. Clearly, secondary interventions are required for open repair, but usually there are things like bowel obstruction, abdominal wall hernia, most commonly, that don't need any specific imaging studies to identify. This question is ongoing. There's a pivotal trial we're participating here in the United States. There's a CESAR trial in Europe, both looking at the question of whether patients with small aneurysms might be better treated with EVAR, although, again, this calls into question exactly which aneurysm is going to be the one that's going to progress to needing clinical treatment, and I discussed that in detail yesterday. And obviously, EVAR should be compared to best medical therapy for smaller aneurysms, and this is incumbent upon us to define exactly what best medical therapy is. So again, I'd like to thank everyone for coming to the conference, and I've found it to be tremendously intellectually stimulating, and I look forward to potentially doing it again sometime in the future. Thank you for your attention. So we're a little short on time, but I know the clinical surgeons in the audience are pretty familiar with most of that data. Does anyone have any specific questions about what we just talked about? Question? Yes, sir.
This is a question of failing EVARs. How feasible is to replace them? Do you replace failing EVARs? What do you do?
Well, I would say in our group, probably Dr. Zarens has most experience with that, but for most of those, depending on what the mode of failure is, the vast majority, there's a percutaneous intervention that's possible that can take care of it with relatively little additional morbidity other than the need for a further procedure and anesthesia. There are some circumstances that require either an open revision of an endovascular graft, and Chris is actually presenting a paper at the Western Vascular Society next week talking about some of his experiences and suggestions for that. and some have to be removed, but I don't know, this last year I don't think we explanted a single device. Have we actually explanted a device this year? Have you done that? No. So almost all the devices can be repaired in place, either with an open revision or a percutaneous or catheter-based secondary procedure. Yes?
What do you think the mechanism is for late-term migration?
Well, see, the word migration is kind of controversial. I mean, you see those differences, but you're not quite sure of the mechanism. As I said, some people think the neck's changing, actually getting longer. And you know, each of the devices have different issues with fixation. There's sizing issues. You know, was it sized properly at the original operation? Chris has done a tremendous amount of work in this area. He's shown, for example, that in one particular device, the risk of migration is closely related to how close it was actually placed to the renal artery. There have been some discussion at this meeting about ongoing biologic activity within the neck being unstable both in terms of diameter and length. I think there's device-specific issues, there's patient-specific issues, there's a variety of things. I know that, well, because we've done work with them, Medtronic is interested in, you know, drug-device hybrids to try to stabilize the biology of the aneurysm once the device is actually in place. That was one of the implications of the posters that was presented at the poster session. So that's an area that's going to be of increasing clinical importance as device usage just becomes more ubiquitous. Yes, Dr. Raghavan.
Assuming calling any motion as migration, in terms of incidence of migration, do you see it over many years? Is it increasing nonstop, or is it bottoming out?
No, I'm not really an expert in the area, and that this wasn't supposed to be a talk on migration, so I didn't come prepared to discuss every observation related to that. But I do know that FDA notice, for example, is basically similar to some of our experiences in clinical practice here, which is that devices seem to be stable for years, and then there's a late problem. And I mean, the incidence of endoleak early can be associated with that. The type of endoleak early can be associated with that. But there is no point beyond which we can say the aneurysm and device are stable and surveillance is no longer necessary. And 3, 4, 5, 7 years after device placement, and this is true for all devices, there's late failure. And Chris also points out that open repair is associated with late pseudoaneurysm formation, issues related to that too. So it's not like there's a gold standard as far as that's concerned. But I mean, device fixation systems, understanding of these issues are imperfect, and further device refinement is necessary in this area. That's an evasive answer, I think, probably.
The preceding program is copyrighted by Stanford University. Please visit us at stanford.edu.